Assalamu alaikum doctors. In this video I am discussing a video station. So first we will watch the video, then I will discuss what type of question we are expecting from this video station. First question is that what I observe in this video. So the description of the video is that I can see a boy in a hospital or clinic setting, appears well, not in distress. He looks average for his age, but I want to plot him on centiles. He seems to be comfortable with no attached devices in the surroundings. His chest is totally exposed from the front and back as well. I can see a doctor doing chest percussion, and at the end of the video there is a chest x-ray showing right-sided homogeneous opacity with obliteration of costophrenic angle. Then the doctor does tap with needle which shows Saras-like clear fluid aspirate. So my DDR for these video stations are uncomplicated pneumonia number 1, number 2 tuberculosis, number 3 COVID-19, number 4 malignancy. Number 5 heart failure, number 6 pulmonary embolism, number 7 pancreatitis. Now history. So what history we would like to ask in this video stations? If cough, analysis of the complaint plus respiratory history. We ask about the onset, course and duration, what make it better and what make it worse. And first time or recurrent occur, when was the last time. Dry or productive, color and amount of the cough. Timing of the cough. Is it more at night? Is it related to exercise? Is there any shortness of breathing or cessation if infant? Apnea will ask. Any musical sound, any cyanosis? Does he have any chronic illness, any other concern? FWASL, that is fever, any weight loss, activity, sleep, these are. And chest, we ask any chest pain, breathing problems, cough, pucks. If chronic, ask about the previous sputum contact to the COVID patient. Past history, we ask like that, travel to endemic area, contact to case of open tuberculosis, contact to COVID patient. Examination. What examination we will do? Local examination of the chest, general examination, assess the general conditions, plot the child on the centiles and assess vital signs, clubbing, cyanosis, BCG scar, erythema nodosum, lymph node, hepatosplenomegaly, cardiac examinations. And management including ABC and manage any problem present, oxygen IV fluid according to his conditions. Assess the vitals and plot on centiles. Painkillers if in pain. Through detailed history and examination. Involve my senior and consultant for admission. Run some test. So what are the investigation you would do? So number 1 is lab. We do the full blood count, clotting screen, urea electrolyte, LDH, protein, albumin, glucose, CRP, culture and sputum culture if possible. If recurrent infections, investigate for immunodeficiency. First line is full blood count, immunoglobulin G, AM, functional antibodies and HIV antibody. If risk factors for coagulopathy or thrombocytopenia, check and correct the before drain insertion. Pleural fluid analysis for gram state and bacterial culture, differential cell count and cytology, AFB, and tuberculosis PCR and culture. Radiology, we do the chest x-ray, PA and AP, no need for lateral. Ultrasound, scan to confirm the presence of effusion, maximum depth in dependent position, differentiate between the simple and complicated effusion, example, loculations, heterogeneous material, localized effusion at time of drain insertion. If history, chest x-ray or ultrasound suggestive of malignancy requires CT chest. Treatment, we give the antibiotic therapy, type of effusion suspected and choice of antibiotics. Effusion following community-acquired pneumonia, we give the coamoxiclav IV plus clindamycin IV. Penicillin allergy, we give the clindamycin IV alone. Effusion following hospital-acquired pneumonia, trauma, aspiration or in immunocompromised child, we give the penicillin or tazobactam. Piperacillin or tazobactam. Penicillin allergy, we give the clindamycin IV. And effusion possibly tuberculosis, discuss with the tuberculosis team. When organism sensitivity is available, Use narrow spectrum antibiotics. Refer to respiratory pediatrician. Number 1, early active treatment reduces the length of illness. Number 2, accept small effusions less than 2 cm deep which are not enlarging or compromising respiratory function and do not need to be drained. Underlying cavitating disease may lead to bronchopleural fistula. Chest drain insertions. Discuss with the respiratory pediatrician, consultant pediatrician, pediatric anesthetic team, usually general anesthetic used, and PICU. Support may also be required from cardiothoracic team plus minus interventional radiologist. If possible, consider simultaneous insertion of long line during general anesthetic. Ensure vascular access before starting the procedure and chest X-ray after drain insertion. If the child on chest tube and not improved, check the tube CRP CT chest after 3-day cardiothoracic surgery after 3 or 5-day accordingly. Indication of referral to cardiac thoracic surgery are if the child is toxic, if not improving for more than 3 days, if the chest tube draining large amount of pleural fluid more than 10 ml per kg per hour, so clamp it to prevent re-expansion pulmonary edema. Intrapleural fibrinolytics is that indicated if thick fluid and loculations or pus, instill urokinase and record fluid volumes into and out of pleural space carefully and accurately. Discharge and follow-up is including with respiratory pediatrician 6 weeks after the discharge, chest X-ray on arrival, and if symptoms persist or recur, early referral to respiratory pediatrician. So this is all about the video station. Please do subscribe and share. I'm CPCH with Dr. Emma Choudhury. Thank you.